If you're preparing for the CCE, this video could save you from a very expensive mistake. I'm going to walk you through the 5 most common failure patterns I see in CCE candidates, drawn from coaching over 60 doctors through this exam, many of whom were on their 2nd or 3rd attempt. These patterns are remarkably consistent, and in almost every case, the doctor knew the medicine, they just didn't present it in the way the examiners mark. Before we get into failure patterns, it's worth understanding why the CCE trips up so many capable doctors. It tests something fundamentally different from every other exam you've sat. You see, the AKT and KFP are internal exams. You read a STEM, weigh up the options, and select the answer. The process happens inside your head. The CCE is the opposite. It's about the external presentation of clinical knowledge. Differentials have to be spoken aloud. Safety netting has to be vocalized with specific, actionable language. And management plans must be structured so the examiner can follow your logic in real time and attribute it to the correct competency domain. The principle I return to again and again when coaching is this: if you didn't say it, you didn't think it. In the CCE, the examiner can only credit what they hear. In other words, reasoning that stays in your head scores 0. This is why knowledgeable and capable doctors fail the CCE. It's not because they lack knowledge. It's because they haven't practiced verbally presenting clinical reasoning under timed, observed conditions, the conditions that the CCE exam involves. And here's why getting it right the first time matters so much. Take a look at this table. After a first failure, the probability of passing the CCE exam drops by nearly 25 percentage points, and it continues to drop with each subsequent attempt. In my experience, this isn't because candidates forget the medicine between attempts. It's because the habits and anxiety that caused the failure compound and become harder to unlearn. The most effective intervention after a failed CCE attempt isn't more study. It's better preparation. Specifically, preparation that targets the verbal performance skills that the exam actually assesses. So with that context, let's get into the 5 failure patterns I see most often and how to avoid each one. Failure pattern 1, presenting answers without structure. Candidates often know the correct answer, but can't communicate it in a way the examiner can follow. Clinical points get buried in rambling, and responses jump between history, investigations, and management without a clear framework. Here's how this looks like in practice. An unstructured answer might jump from mentioning a medication to a differential, back to an investigation, then to a referral. This information is all correct, but it's impossible for the examiner to follow. A structured answer, on the other hand, moves through a consistent sequence. The examiner can track it in real time and attribute it to the correct competency domain. Here's the fix to presenting answers without structure. Before you speak, have a mental framework for every question type. For a management question, I recommend splitting your answer into pharmacological and non-pharmacological management, then working through each systematically. Under pharmacological management, distinguish between symptomatic treatment and disease-modifying treatment. Under non-pharmacological, cover lifestyle factors, referrals, patient education, safety netting, and follow-up. Structured mnemonics like SNAP PW and Recap R can help you cover all non-pharmacological management factors without relying on memory under pressure. You can also use established frameworks like Socrates for history taking, ICE for understanding the patient's perspective, and SPIKES for breaking bad news. These frameworks all give you a consistent structure to fall back on so you present your clinical reasoning clearly. Failure pattern 2, rambling rather than reasoning. This is related to poor structure, but the underlying problem is different. In most cases, rambling candidates aren't disorganized, they're anxious. They try to cover everything, hoping that volume will compensate for uncertainty. It doesn't. Examiners are trained to identify focused, logical, clinical reasoning. A long answer that touches 12 differentials without prioritizing any of them signals that you can't distinguish the likely from the unlikely. It also makes it very difficult for the examiner to pick up on the key information, especially if you're speaking quickly, which most candidates do under pressure. The fix is twofold. First, slow down and enunciate. Give the examiner time to hear and attribute what you're saying. Second, and this is the most important part, prioritize ruthlessly. If a question asks for differentials, lead with the 2 or 3 most likely given the clinical picture. Explain briefly why each fits, then mention 1 or 2 serious conditions to exclude. That's a complete answer. The instinct is to cover everything, and that is playing it safe. But in the CCE, it achieves the opposite. Failure pattern 3, over-investigation. Ordering every available test is one of the most consistent failure patterns I see. When asked what investigations they'd order, candidates often default to a comprehensive list rather than a targeted selection appropriate to the specific patient. The CCE rewards clinical prioritization. The question isn't what tests exist for this presentation, it's what tests does this patient need given their history, risk factors, and the clinical picture in front of you. An experienced GP doesn't order everything. They order what's evidence-based and what will change their management. That's the standard the examiner is scoring against. Here's the fix. For every investigation you mention, ask yourself, will the result change what I do next? If the answer is no, don't order it. Also, be sure to practice articulating why you're selecting each test. For example, I would order iron studies because I need to rule out inflammatory bowel disease given the patient's history of abdominal pain. That reasoning is what earns marks, not the length of the list. Failure pattern 4, missing red flags and patient safety considerations. One of the most heavily penalized patterns in the CCE is failing to demonstrate that you're a safe clinician. And this doesn't usually mean missing something obvious. It means not considering the things a careful GP would always rule out, even when unlikely. For example, a patient presenting with chest pain will most likely have something benign, but it's still essential to vocalize that you'd want to exclude an MI or a PE. Not because you think that's the diagnosis, but because a safe GP always considers it, even if it's a young, healthy, fit male. The same principle applies to prescribing, let's say, medication without checking for interactions, not conducting a suicide risk assessment in mental health presentation, or failing to address consent, cultural safety, or medico-legal considerations. In short, if there's a safety consideration that exists in the case and you didn't name it, it's really hard for the examiner to give you credit for recognizing it and for thinking that you are a safe candidate. This is the classic, if you didn't say it, you didn't think it principle. And this is where it matters the most. Here's the fix. Build a safety screen into every station. Before you pursue the presenting complaint in depth, actively ask yourself 4 things. 1, what is a serious diagnosis I need to exclude here, even if it is extremely unlikely? 2, are there any specific prescribing risks at play here? 3, what about a mandatory reporting obligation? And 4, is there a cultural safety consideration? These don't need lengthy discussion. They just need to be named. Vocalizing them takes seconds, and it's often the difference between passing and failing a station. Okay, let's move on to failure pattern 5, missing cultural, ethical, and medico-legal dimensions. The RACGP increasingly tests cultural safety, Aboriginal and Torres Strait Islander health considerations, ethical reasoning, and medico-legal awareness. These are areas where candidates with a strong clinical knowledge routinely lose marks, not because they lack the instinct, but because they haven't practiced applying this reasoning in a structured, vocalized format. Here's what this looks like in practice. A candidate manages a clinical presentation competently, but doesn't consider the medico-legal implications of a mandatory reporting scenario, or doesn't address the cultural safety dimension of an Aboriginal or Torres Strait Islander patient. That candidate is leaving marks on the table in domains that are actually straightforward to prepare for. To fix this, for each case you practice, Actively ask yourself whether there's a cultural safety consideration, any ethical elements to the case, or any medico-legal obligations that are at play. These are core competency domains the RACGP is explicitly testing. Practice being cognizant and identifying them in every case you work through, even when they're not the primary focus. So you're building the habits for identifying them automatically by exam day. If you recognize any of these patterns in your own preparation, the most important thing you can do is start practicing differently, not just studying more. Fellow Academy's free trial includes 8 CCE cases designed to train exactly the structured performance skills I've been describing. I'll leave a link below. I've also got a separate video on how to structure your study for the CCE. I'll link it here.